So those are two mechanisms we talked about previously. The third one is the myogenic response. And so the myogenic response is a change in vascular resistance that then changes the stretch on the blood vessel. Again, absent of any external factors, absent of any neurons, of any hormones. This is intrinsic or inherent to the blood vessel itself. And it's really a protective mechanism for the blood vessel. So if we have increased perfusion to an area, this is going to put stretch on the wall of those arterioles. And that stretch results in contraction or constriction of the smooth muscle. So again, an inherent property of the smooth muscle, a protective mechanism to prevent overdistension, overstretch, and that causes reflexive vasoconstriction, which decreases flow. And the whole purpose of this is to keep the blood flow relatively constant, right? To auto-regulate that flow. So increased stretch means increased constriction, means vasoconstriction, means decreased flow, right? So that is the myogenic, and myo meaning muscle, the muscle or myogenic response. So let's walk through um, that response here. So here's our arteriole. We send more perfusion to the arteriole, which increases the flow rate. That results in a reflexive stretching to the smooth muscle of that arteriole. That stretching results in vasoconstriction as a protection. And then that increases resistance, which in turn decreases the flow. So this becomes a negative feedback response to increased flow, which can then go back and shut off that response when the flow has decreased, okay? And so this, again, is inherent natural reflex in the blood vessel. All right, so those are three intrinsic mechanisms. That was the third and final one. We're actually going to shift now to talk about some of the extrinsic factors. And in order to talk about the extrinsic factors, we want to think about how cardiac output is regulated during different states. So whenever we're, we're exercising, whenever there's increased exertion, the cardiac output is going to increase as well, but the proportion does not increase. Okay, let's say I'm running a mile on the treadmill or on the track. I don't automatically send more blood from the heart to my muscles. What happens instead is I have to take or divert that blood from somewhere else. So that dilation of blood vessels to my skeletal muscle, to my heart, to increase heart rate, to increase flow peripherally, that happens at the cost of constricting blood vessels to other organs like the GI tract, which are presumably less active, and the kidneys, which also take a significant chunk of cardiac output as well. So I have to shunt blood away from those less important organs, or at the time, less important organs, towards skeletal muscle, towards the heart. All right, so there's a disproportionate diversion of flow towards the organs that need it. Okay. And just looking at what this, the different proportions of cardiac output look like. So at rest, we have about 5 liters per minute being our total cardiac output. And the skeletal muscle gets about 1 liter. The kidneys get about 1 liter per minute. GI tract gets a bit more because the GI tract is more engaged when you're in the rest and digest. Remember, the parasympathetic system, the rest and digest is slightly more predominant at rest. So GI gets a bit more than it would normally. Brain gets about 0.7 liters, and then other organs like the heart get 0.2, and then just lumping some of the other body systems, the skin, as 0.6 liters, all right? And then if we look at what happens during exertion, during physical activity, during times of stress as well, so maybe not physical exertion, but stressful states, anxiety-provoking states, that shunts more blood, more cardiac output to your skeletal muscle. And in a very large proportion, so about 20 liters per minute towards your skeletal muscle. You're going to have a significant chunk go to your heart. So your heart bumps up to about 1.15 liters per minute. And then other systems proportionally decrease. Kidneys drop down to 0.85, GI tract drops down to 0.1 or so, and then skin and others drop down significantly as well. Okay, notice how brain drops down just a little bit. The brain is very selfish, very oxygen dependent. And so the brain is not going to take much of a hit. It's going to drop a little bit to sacrifice for cardiac output, but it otherwise is very metabolically demanding. Okay, so this is how we can shunt blood or divert blood to the organ systems that need it during times of high demand. Right. Let's pause here. We are going to continue on and look at extrinsic control of the arterial radius and therefore mean arterial pressure. So we want to remind ourselves of this. We discussed this earlier. Flow is equal to the pressure gradient divided by any resistance encountered. And we can compare that to our physiology. Our cardiac output is equal to our mean arterial pressure divided by the total peripheral resistance encountered, especially that in the arterioles. And then we can rearrange this equation to identify factors that in turn affect the mean arterial pressure. So that's going to be cardiac output times total peripheral resistance, okay? So cardiac output and TPR, those factors will in turn regulate MAP. So the mean arterial pressure is dependent on the amount of total peripheral resistance encountered. And we know that the radius size is what determines the resistance, all right? So modifying the radius size in turn modifies our total mean arterial pressure. Now, when you think about the extrinsic controls, this is basically the sympathetic nervous system and hormones. They have a very similar effect. If you think back to the mechanisms used for sympathetic control, which are our adrenergic receptors and binding of either norepinephrine, epinephrine, a little bit of dopamine in some cases. So that will have the same response as if we had the hormones at those tissue beds, right? Neurotransmitter, hormone, similar response at the tissue level. So those are some of the extrinsic mechanisms. So things that are not within the vessel itself, things that are external, like the brain, the spinal cord, and then certainly hormones. Now, when you think about this, the sympathetic nervous system, first off, is highly innervating these arterioles. So there's a lot of sympathetic neurons, preganglionic neurons that go and attach onto these smooth muscle in the arterioles. And so that is where we're going to find the adrenergic receptors. So the adrenergic receptors here allow for the binding of those hormones, which will in turn bring about constriction or vasodilation. Now, these are not going to be in the brain. Again, the brain is a very unique case. We'll point this out quite a bit. It does not have a lot of or obey a lot of the rules that we'll see for skeletal muscle, cardiac muscle, even for the GI tract. And it doesn't have a lot of these alpha adrenergic receptors, which is what brings about widespread vasoconstriction from the nervous system or hormones. So the brain is kind of rebellious in this way. It's also very selfish. It needs a bit more supply, and it doesn't divert its blood to other systems very easily because it doesn't have as many of these receptors. So we're going to see norepinephrine binding to these adrenergic receptors. That brings about vasoconstriction, and vasoconstriction decreases our arterial radius, which translates to increased mean arterial pressure because we increase the total peripheral resistance. So think about this in the sense that when you make the radius smaller, you put more pressure on that vessel, but you also increase the flow. Okay, you increase the flow because now the blood is under higher pressure, and that is going to increase flow moving out to those capillary beds. Let's talk about the receptors that we find on skeletal muscle and on cardiac muscle. We mainly find beta 2, but we also find some alpha adrenergic receptors as well. So mostly beta 2, but then both alpha and beta 2 can be seen. Now, the response that happens when norepinephrine binds to an alpha receptor is widespread vasoconstriction. So because this is found throughout, we're going to see vasoconstriction more broadly, more generally. And then when epinephrine binds, right, so slightly different affinities here, when epinephrine binds to alpha and beta 2, we're going to see two different things. And this is going to be dose dependent. So at low concentrations, beta 2 is predominant, and that causes vasodilation. At high concentrations, both alpha and beta 2 receptors are engaged, and that causes vasoconstriction at the alpha and still vasodilation at the beta. So low concentrations, beta 2 only. High concentrations, both of these responses will be seen as epinephrine binds to both of these receptors. And then we also want to think about the affinity here. Epinephrine has a greater affinity for beta 2, which is why it binds at even very low concentrations. So lower concentrations, higher affinity, higher affiliation, or higher attraction, which causes vasodilation at those low levels. And then as far as the, so the concentration dependent, meaning that lower concentrations engage beta 2 only, which brings about vasodilation. Similar point that I was making on the previous slides in terms of this being dose dependent or concentration dependent, okay, epinephrine specifically. All right, and in higher concentrations, it binds both. So both alpha and beta 2, the response that we'll see for vasodilation at the beta 2 is going to be decreasing total peripheral resistance, decreasing blood pressure, and then the response that we see when it binds alpha receptors is vasoconstriction. This is at most vascular beds. So beta 2 is only skeletal muscle and cardiac muscle. Alpha is pretty much everywhere. It's a bit more widespread. It's more global vasoconstriction, except the brain, right? Excepting the brain, not including the brain there. And then that vasoconstriction is what maintains total peripheral resistance everywhere else. So as we are decreasing some of our blood flow to the causing vasodilation to skeletal and cardiac muscle, decreasing total peripheral resistance, we want to maintain our TPR everywhere else. So that is how we cause vasoconstriction more widespread because of alpha receptors. And then again, the dominant effect is vasoconstriction. And the reason is we don't want to drop our blood pressure too low, right? Remember that although we're shunting blood to one organ system, we still want to be mindful about the level of perfusion that's happening to our other capillary beds, our other tissue beds as well. So that dominant effect being vasoconstriction, especially at high levels of epinephrine, is really important to maintaining our total perfusion and maintaining our total blood flow everywhere else. Now, the second mechanism was hormonal control. So one is the sympathetic nervous system. Two is hormonal control. Similar responses, but just different mechanisms. So epinephrine acting as a hormone. This is when it's released from the adrenal medulla. And if you recall here, adrenal medulla is the inner aspect of the medulla that releases hormones that act very similar to the neurotransmitters when they bind to these receptors, right? Just different sources of being released. So that release can also stimulate the same response we just described, low levels causing vasodilation at heart and muscle, high levels causing widespread vasoconstriction except the brain, along with vasodilation to heart and muscle, okay? And then vasopressin is another hormone. This is also called ADH or antidiuretic hormone. This is released from the posterior pituitary, and this increases water reabsorption in the kidneys and also causes vasoconstriction. So vasopressin is one of those hormones that also tries to preserve and maintain our total perfusion, okay? So if you have a patient crashing out, bleeding out, losing volume, or dehydrated, you want to administer vasopressin. That's going to get your vasoconstriction up, that's going to reabsorb water, that's going to increase your total peripheral resistance and sort of maintain the perfusion. Similarly, angiotensin 2, another kidney-related hormone, this also causes vasoconstriction and can increase total peripheral resistance, thereby maintaining our arterial pressure. Okay. So these are very important responses to keep patients alive, especially when they're crashing, especially when they're losing volume, trauma injuries, losing blood. These are the hormones that we need. These are the responses that we need to keep their perfusion going, right? Clamping down on those vessels. And you would kind of think about this in the opposite direction. Why would I want to constrict vessels if a patient is bleeding out? You absolutely want to constrict vessels if a patient is bleeding out, right? You want to maintain that pressure. You want to keep the blood within the circulatory system. And so you want to increase total peripheral resistance in order to help maintain mean arterial pressure.